So if you look at spirometry and FEV1, these are the ACSM recommendations based on spirometry function to look at mild, moderate, severe, and very severe COPD. So again, it's obstruction. So how much air are they exhaling in 1 second? What is that percent? So greater than 80% mild, you should be able to exhale almost all of your air within 1 second. And if you see as the numbers go down, then that can be an indicator of COPD. So very severe, they're barely getting out any of their air out of their lungs. So some of the physiological changes with COPD, as mentioned, it is difficulty with getting air out. So expiration, the lungs remain hyperinflated. So their airway size, because of the excess mucus production, it does take more energy to breathe. Increased dead space. So if you remember from physiology class, dead space is where there is no gas exchange taking place. Poor alveolar ventilation. So the alveoli are not getting good gas exchange. They can be low on oxygen, so hypoxemia. They use little devices called an oximeter in pulmonary rehab to look at your oxygen saturation. The gas exchange itself may be abnormal due to damaged tissue. Overall, people are going to have poor aerobic fitness. Generally, lungs do not limit people in exercise. It's typically going to be something like your cardiac output that's going to limit your VO2 max. But with people who have lung disease, their lung is going to limit them in exercise. And of course, as we've also talked about too, people tend to become deconditioned due to inactivity. So you get this further downward spiral of deconditioning with less activity. And a lot of people who have COPD have anxiety and depression. They have a disease that is progressive and, may eventually take their lives. So it's not uncommon for people to have, difficulty with that. Treatment for COPD, looking at the obvious one, patient education for what's going to be best for them, and getting people to stop smoking if they're still smoking. So that's the first line of defense. As the disease progresses, and it can be a very slow moving, slow progressing disease, people may need to go on bronchodilators. They may need to use corticosteroids, inhalers. Anybody who has more than mild COPD, we are probably not going to see them in our exercise settings. They are most likely going to be in a supervised clinical exercise setting. And that way they may be able to work out with the oxygen. And at, the worst, people may need to have surgery. Medications in COPD, bronchodilators, that seems to be the most common. They can have side effects. They're very much like your sympathetic nervous system. They mimic your beta receptors, so they can cause tachycardia, fast heart rates, and irregular beats, and so they mimic caffeine. Diuretics, again, help people get rid of some of the fluid and the mucus in the lungs, can cause electrolyte disturbances. We've already covered that with heart disease. Beta 2 receptor agonists, those are ones that relax the bronchial smooth muscle tissue. Glucocorticoids such as prednisone, I'm sure most of us have heard of prednisone. So it's a very strong anti-inflammatory, and it can be very effective, but long-term prednisone use can increase someone's risk for osteoporosis. Prednisone is used with a lot of the conditions that we're going to be working with this semester, so it's something to keep in mind. And of course, as well as we mentioned, the anxiety and depression medications.